Good morning, everybody. First of all, I would like to welcome all of you in this first online conference of POPMA 2025. And at the outset, I would like to pay my regards to this beautiful organizing team of the conference who have organized such a beautiful academic extravaganza for 2 days. And a special thank you for giving me this platform to present my talk on the red and white patches of the oral cavity, their clinico-histopathological correlations. So when I was thinking to plan this presentation, I thought, why not start off with a few questions that are always there in our mind whenever we see a red or a white patch in an oral cavity in a patient. So my aim would be to answer or to help all of you answer all these questions by the end of my presentation. Very basic questions. What do we mean by red or the white patches? Whenever we talk of red and white patches, we always hear the term oral cancer, OPMD. How are they related? And every time, by and large, whenever any clinician sees a white or a red patch, they take a step backwards. That, well, let's refer it. Why? Why can't, in other words, what can we do to tackle these red and white patches in our own private clinical practices? So, this is a paper by Dr. Chaturvedi from TMC Mumbai. Basic things. What is a white patch? It is a leukoplakia. Leuko means white, plakia means patch. A red patch would be an erythroplakia. But they are potentially malignant, which means at present they might not look malignant, they might not be malignant, but they are potentially malignant. And more importantly, they may be missed. So whenever they are missed in a person in an oral cavity, they keep on proliferating. And then that same particular potentially malignant white or a red patch, erythro or a leukopenia, will end up into a malignancy. If we read the third point, we know that this has been now put in literature that all those potentially malignant patches do have a very fair chances of turning into a frank malignancy. Certain areas, anatomical areas in the mouth, which are more dangerous to have malignant changes, floor of the mouth, things like that. So whenever we talk of potentially malignant lesions, we talk of OPMD or oral potentially malignant disorders or diseases. What are they? Well, it is there in our screen. They are heterogeneous group of oral mucosal lesions, as we talked, with an increased risk of malignant transformation. Most common ones are leukoplakia, erythroleukoplakia. Erythroplakia is a red patch. Erythroleukoplakia is a mixed red and white patch. Oral submucous fibrosis, PVL, erythroplakia, as I mentioned before. Hyperplastic candidiasis and oral lichen planus, now the common consensus is they might not be potentially malignant, but for all practical discussions, let's keep it under the discussion. But why do we need to tackle the red and the white patches? Oral cancer, how dangerous it is. We know the data says so. This is the data from National Oral Cancer Registry. Nearly 60,000 new cases of oral cancer reported annually. And most importantly, most of the times we follow what the West gives us, but they have approximately 5%. Oral cancer accounts for only 5% of all the cancers globally. In India itself, the 5% jumps up to 40%. So if at all any research or any good thing about the treatment and the management of cancer will have to come for the world, it has to come from India. We are very clear about it. There is no doubt about it. Well, it remains a major health problem. Let's see what 2030 shows us. They are typically detected in their advanced stages. This is a very important line. Oral cancers are typically detected in their advanced stages. More importantly, early detection and prevention will reduce this burden. And then if we are able to tackle pre-malignant lesions, red or the white patches in a very earlier stage, and if we think it as a spectrum, where the bigger part of the spectrum is at the advanced stage of an oral cancer, OPMD represents a very early stage. I mean, just a seed. Whereas an oral cancer is a fully grown up tree with roots inside the soil and involving everything. And dental surgeons would be the ones because they are peeking into their patient's mouth day in and day out. That if at all oral cancer has to be nipped in the bud, it has to be done by the dental surgeons. I mean, they stand the best chance to do it. Do all white and red lesions classify under OPMD? No, but then every oral cancer starts with one. So the idea is to look for any white or a red patch or a mucosal lesions or any mucosal abrasion in the mouth, so that we don't leave even one OPMD in the mouth and then give it a chance to turn into a full-blown carcinoma. This is a full-blown carcinoma. Chances are could have started with a very simple, this kind of a thing, which has a very definite clinical feature, but it is asymptomatic. That is why it may be missed. If it is missed, well, then it keeps on proliferating, and then nobody can miss this kind of an advanced oral cancer. So, idea is to identify these things and then nip it to the bud. Any trauma, for that matter, mechanical or chemical, in our mouth would show up as a red or a white patch. But not every red or a white patch would be an OPMD. There are immune-mediated disorders, fungal infections, and we need to. Idea is to categorize them in some. Under a diagnostic word, so that then we can think of the treatment, and then we can think of a management. Whether this particular red patch is an OPMD, or is it a pemphigus, or is it a lichen planus, or is it an inflammatory ulcer? How do we do it? Let's see. These are all the red and the white patches we encounter in our daily practices. First of all, chief complaint: pain, stomatoparosis, incidental finding, where the patient will not know about it, and the dental surgeon will tell the patient that, well, you have this kind of a thing. Pain. If the patient complains of pain, it is an acute onset thing. Think of aphthous ulcers, herpes simplex virus infection. Now, this is an ulcer, and if my cursor is visible to everybody, there is a very typical characteristic erythematous halo around the ulcer. Though there is a white patch also, but then there is an inflammatory halo around this ulcer with a pseudomembrane. It is painful. This is not an OPMD. This is a plain aphthous inflammatory ulcer. When we think of stomatoviruses, patient will complain of burning sensation while eating a normal food which other family members are not complaining about. Think of immune-mediated conditions. These are the conditions which are there on your screen, very characteristic of oral lichen planus. So if we keep following what the patient is saying, if we take a proper history, most of the times, more often than not, we'll be able to diagnose that particular white or a red patch in the mouth, and then think of the management. When we think of incidental findings, sight becomes very important. For example, this is the lateral border of the tongue. Now, if you pay attention to these two teeth here, these are 7 and 8 KES, and this is a wall which is there, and this kept on hitting this part of the tongue, the lateral part of the tongue, and thus we had an ulcer. The patient didn't complain much of any pain. So this is the sight is very important. Again, lateral border of the tongue. From the chronic impingement from a tooth, you can actually see a tooth mark over here. This is the whole lesion. Vestibule, most common site for the people who use canny, because this is the area of placement of the canny, and thus the white patch over here. Again, a white patch. You can see that the patient is a tobacco user. Particularly, this is the place in the mouth where he used to keep his quid or the canny, which he has a habit of consuming. So, thus we have a very typical white patch over here, which is completely painless, asymptomatic, may be missed. Retrocommissural lip. Now, this is a very important site in the patients who are addicted to smoking cigarettes, smoking cigar, BD. Most of the times it's BD. But we need to know this before we actually peek into the mouth, that if a patient is in a habit of smoking BD or a cigarette, this is the area, retrocommissural lip. bilaterally, unilaterally, where you might find a white or a red patch. If you do not know this, chances are you will miss this finding, because this is the area where we keep our mirror to retract the cheek. And if we do not know that this is the area where we have to especially pay attention to, you can very easily miss this side, the retrocomitial lip. In the background of the patient came history of smoking. Multiple sites, very important. Now, this is one exophytic lesion. There is another lesion here. Now, you can see here in the gingiva, there are too many lesions. Multiple sites, for example, multiple sites, female non-smoker use, you can immediately start thinking of varicose leukoplakia. Size, we'll talk about it later, because that majorly size would decide whether you are going to take an incisional or an excisional biopsy. The types of the spread of the presentation, plaque or papular, like a very flat thing on the oral mucosa, macular, which is not raised from the normal surface of the oral mucosa, reticular, very typical. Now, if we see a white patch, which is reticular in pattern, and it is painless, asymptomatic, mild symptoms of stomatoviruses, we don't need to go further. We know we are looking into a oral lichen planus. Annular pattern, geographic term is one thing. I mean, a very typical annular pattern. You don't need to move ahead. You just take the history, see the lesion, and then you're already having a diagnosis with you. Ulcers, as I already told, this is now these are two ulcers. This is an inflammatory ulcer. If my cursor is highlighting it, it is an erythematous halo, as I was talking, but there is no halo over there. This was painful. This was absolutely painless. This had a history of 5 days. This has a history of 3 months. Both are ulcers. But in this case, we need to investigate further. In this case, we know that this is an inflammatory ulcer, will heal on its own, or you have medications to give. Ulceroproliferative. There it is ulcerative and it is raised, cauliflower-like and all those things. We can see here, but this is a white patch. Now we can very clearly see a difference between a patch and an ulceroproliferative disorder, which is proliferating above the level of the oral mucosa. So these are few very common presentations. Very important sign when you are now palpating the lesion or touching the lesion, you have to see the scrapability. The photo in your the left side of the screen is not a scrapable lesion; it is a non-scrapable lesion. The thing over here is just a scab which gets removed, because this is a patient where of um, a habit of candy consumption. It is because of that slake line. This effect is there. Books say sometimes pemphigus will also give a similar kind of a presentation with the tissue tag. This is not scrapability. This is an unscrapable lesion, whereas a scrapable lesion is this, where something has deposited on the mucosa. Now we know that if it is a scrapable lesion, it is a white lesion, the patient is having some kind of a systemic disorder. We don't need to delve. We know perhaps we are looking at a case of candidiasis. So this is scrapability. This is non-scrapability. Very important point when you are clinically correlating any mucosal alteration. Uni or a bilateral lesions. Common things, linea alba buccalis, we know it is an anatomical aberration. We don't need to delve much into it. Lichen planus. Now, this is the same patient. This is the other side. Normally, lichen planus will have a metacranous bilateral onset. So there was we got a patient where it was a synchronous thing, but then this reticular patch, hyperpigmentation, because it is a healing lesion because of melanin pigmentation, diagnosis done, oral lichen planus. We don't need to take biopsy, nothing. So just by looking at a few characteristics of a particular lesion in the mouth, by following the history, we can actually categorize that particular white or red patch under a diagnosis. Important palpation, when you palpate it, if it is soft, if it is leathery, well, fine. If it is indurated, then it is bad. Normally, you get a cracked mud kind of an appearance, bit leathery to touch, bit rough to touch. All those things, the more the mucosa proliferates inside, the feel of that particular mucosal aberration changes. When it is indurated, well, it is bad. Now, this was how the ulcer will look. What else to see for? You look for risk factors. The biggest risk factors when you're looking into a red or a white patch is tobacco use in any form. plus ill-fitting dentures, malpose tooth, especially the eights. That is why I think now the recent consensus about impactions is that whenever you are disimpacting a 3/8 or a 4/8 in the same sitting, also take out 1/8 or 2/8, because once the 3 or 4/8 is out, the antagonist tooth will super erupt and then it might start hitting on the retromolar trigon. This is again, retromolar trigon is again a very vulnerable anatomical site. So sharp malpose tooth, ill-fitting dentures, duration. Well, any red patch, any ulcer, any white patch in the mouth for more than 1 month. I mean, book says I think 2 weeks, but let's keep it for 1 month. If it is not healing, you have to take some action regarding that particular patch or an ulcer. Tenderness, we know about it. Painless the lesion, poorer the prognosis. And if it is indurated, well, even worse. So now combining everything, there is a white or a red lesion on the now we know what are the vulnerable sites: lateral border of the tongue, floor of the mouth, vestibule, where they keep their quid. Duration more than 1 month, you should start thinking that this is not something which we can let go. Add to it that it is a completely non-tender touch lesion and patient has not complained of any pain. Plus there is induration, the risk goes higher. Plus there is no obvious etiology. There is no acute trauma, no toothbrush trauma, no cheek biting, lip biting, all those things. Plus there are risk factors. The patient is an alcoholic, the patient takes some kind of a tobacco, or there are malpose teeth, there is a chronic irritation from any cusp or a third molar or whatever. So risk factors are also there. Now, if the lesion is present without any obvious etiology, plus there are risk factors present, we perhaps are looking at a lesion which now is an OPM or oral potentially malignant disease. Combining all the factors, we should be now able to come up with some kind of a provisional diagnosis. And then once we are done with the provisional diagnosis, there would be a treatment plan. If it is a inflammatory ulcer, analgesics, local or maybe systemic analgesics, topical corticosteroids in some extent, yes, if you are confirmed that we are looking at a pemphigus or a lichen planus. Biopsy, if you have decided that nothing fits the bill, you cut the tissue, observe it under the microscope. More often than not, we see the prescription writing of triamcinolone. Triamcinolone does not work everywhere. If you really have to start with some kind of a empirical therapy, you can go with some kind of an obtundant paste. Metronidazole might help. Tacrolimus might help. Triamcinolone is a topical corticosteroid. Does not work anywhere. Doesn't work like that. As mentioned, there is no obvious etiology. Risk factors are present. It's a dysplastic lesion. Adjunct techniques are very helpful now to tell you what to do ahead. Once we talk of, I'll give a very short review of the adjunct techniques which I use in my practice. Basically, the adjunct techniques will tell you that this particular white or a red patch or an ulcer has dividing cells. It will not tell you whether this is an OPMD or whether it is an inflammatory ulcer or whether it is a cancer. It will just tell you that it has dividing cells. You have to fall back on the history. You have to rule out any acute causes, any acute inflammatory causes. For example, somebody who has undergone disinfection 3 days before, if you do a adjunct technique on that healing site, it will give a false positive reaction because there are dividing cells. It's a healing lesion. But if there is a red or a white patch or an ulcer in the mouth which has dividing cells, which your adjunct technique will highlight, but there is no obvious etiology, there are no risk factors, then you might be looking at something which is dysplastic in nature, and histopathology still now is the gold standard. Basic Wellscope, Visilite, Toluidine blue, these are the, I have also mentioned the principles on which they work. None of them preclude the need for biopsy. They'll just tell you that, well, this is an area in the mouth which has dividing cells. Wellscope looks like this. I do not have a picture of Visilite. Even Wellscope I've taken from Google because I don't use Wellscope or Visilite. What I use personally in my practice is Toluidine blue. These are my clinical pictures. no added advantage of Visualizer of the scope I found over toluidine blue. So this fits my bill. Plus, most of the things about toluidine blue are there in the net. If you start using toluidine blue, you will know about it. But one thing which I experience in our practice is that when you show the patient the real-time change in the color of that particular, because we have to remember one thing, that all these OPMDs, if we talk about, are asymptomatic. Patient is not really bothered about what's there in his mouth unless he sees that there is a color change, that this particular blue ink has got this area of my mouth where I keep my canny. That is when he will actually get oriented to whatever now you will tell him about biopsy or quitting the habit. So I think it changes the patient perception, the toluidine blue, because of the stark difference between the color, coral pink and the blue. For example, this is an ulcer which I had already discussed this picture. 1% toluene blue counter stained with 1% acetic acid. Now we can very well appreciate this small area. Now this is because of chronic irritation. It was non-tender and all those things. Now it has also retained the stain. So there is no reason why there should be dividing cells, because there is no pain, nothing, no healing lesion. It might be a dysplastic lesion. Again, this is a place where the patient used to keep his quid. Toluene blue counter staining with 1% acetic acid, we can see that it has very nicely delineated those dilated ducts of the minor salivary glands. You show the patient this picture, and the patient immediately will sit next to you and tell you that whatever you tell me about quitting the habit, I'll agree to it. A very small ulcer over here. We were not able to really delineate the ulcer. It was, I think, 7 months history. We did it toluene blue counter stained. It very clearly demarcated the lesion. Once we do this, we then decide that, well, we now need to take a tissue out of this thing and then see what the cells tell us, what is the story there. So it provides biopsy. We know it provides you with final diagnosis. It confirms your provisional diagnosis. You think it is a lichen planus, not healing, you take a biopsy. Biopsy will tell you that yes, it is a lichen planus. Cytology is a very good. Most of the time, cytology is done where the patient is a little concerned about getting the invasive procedure of biopsy done, but many times it helps. Should always precede the tissue biopsy, that is the excisional or the incisional biopsy. Where will you do it? Where the symptomatic treatment cannot be rendered. You do not do a biopsy on an inflammatory ulcer. You can render a symptomatic treatment. Chronic unhealing ulcer, and then, as I mentioned, size will determine whether you will do an incisional or an excisional biopsy largely. Because if you think that provisionally invasive lesion, you might do an excisional biopsy without seeing the size. That is, I think, the recent consensus. Often, the representative areas can be missed in incisional biopsy. Vital staining will help. Now, this was a lesion. We stained it, and then this was the area which had the maximum retention of the stain. So we were quite confident this is the representative section. We took it. This came out to be a moderate dysplasia. Going ahead, again, this was an ulcer over here. This is the toluene blue after counter staining. Very small ulcer, came out to be a frank, well-differentiated squamous cell carcinoma. So you won't miss the representative section if you take the help of the adjunct techniques. One more case, a very vulnerable site, lateral border of the tongue. This is the toluene blue picture. You can see the dysplastic cells over here amongst the muscles. So this was a squamous cell carcinoma. This was a very interesting case. We got a patient with multiple ulcerations, more than 7 months. We tried everything, nothing was working. Then we took a biopsy. Again, we tried triamcinolone, sinolone, and it actually worsened the situation. Biopsy revealed it to be histoplasmosis. The patient was started on itraconazole, and then once the patient was started on itraconazole, you can see that this healing lesion is there, the gray pseudomembrane. The patient was healed completely in this case. Again, the white papular thing, scrapable, we took it out. It was extending from RMT till almost the retrocommissure, the whole thing, scraped the hyphal part, and then there was an erythematous patch inside. That is why hyperplastic candidiasis, whether it is potentially malignant or not, we don't know. But in this, you will be able to appreciate what we found out. We took two biopsies in this case, one from the posterior area, one from the anterior area. The anterior area showed us this kind of a picture. There it was dangerous because of those bulbous drop down elephant foot retirages. But still, the posterior part showed us this. Now, this was bad. You can see the post reaction, the inflammatory reaction, and this was severely dysplastic epithelium. Chronic ulceration, the duration was 3 months. The patient was also in the habit of taking supari. Now, this was an ulcer. You can see the supari stains have actually stained the ulcer body also. This was what my staining showed me, but this was not indurated. This was not. It was very. If you close your eyes and touch the whole thing, if you run your finger from here, you won't even feel that you are running your finger through an ulcer. It was completely painless though. So literature dictates we do a incisional biopsy. A wet shade biopsy, you can actually see this is the ulcer and this is the healthy margin, primary closure. The rest of the ulcer is still seen here. This was a chronic ulceration. There was no dysplasia. The patient was happy. You can see the over here, plus the granulation tissue, a better picture of the granulation tissue. So now you have actually tackled a lesion which could have turned dysplastic, and now at least the patient, whatever happens to him, will not land up in dysplastic ulcer, not only because you have operated on the patient and you have taken it to a full closure, but also because now after undergoing everything, after interacting with you, he or she now knows that in my mouth, if there is any patch or an ulcer which is not healing and it is painless, I need to consult a doctor. So once the patient is aware, they will land up to a professional. This was a very interesting case. Chronic ulcer on the lateral border of the tongue for 7 months, painless. History of cigar smoking. Mildly tender arm palpation. We took an excisional biopsy. This was 5th day post-op. You can see the suture. Now, this is what the cellular level story was telling us. I mean, amongst the full thing of the section, these are the areas which we found was a little making us uncomfortable because of the types of the retirages we are finding here. Another picture, these are the areas which we really found was concerning, especially the areas here where the retirages were taking a teardrop kind of an appearance. Now, these are the areas where you can see some mitotic bodies, hyperchromatic cells, very mild pleomorphism, but still there. Even mitotic bodies are typical and they are also in the basal layer, but then they are there. Plus, the lymphocyte host reaction which we are seeing in the connective tissue. Now, these are again areas, again mitotic bodies. You can see a lot of open facet nuclei. You can see a lot of hyperchromatism, mild pleomorphism. So we decided to go with the final diagnosis of a very low grade dysplasia. We have done away with the three naming system: mild, moderate, severe. Now we do a low grade or a high grade dysplasia. This was a low grade dysplasia, completely taken out. This was 15th day post-op. You can actually appreciate the granulation tissue forming. This patient, I befriended him, so he kept on sending me pictures. Nearing a month, and this is after a month. So complete healing achieved. And more importantly, not only complete healing, the patient now I cannot track whether the patient has left the habit of cigar smoking or not. He might say that, oh, I have never touched a cigar after it, but I can't believe him. That's okay. But now he knows that, well, if I'm still smoking my cigar, and now there are lesions in my mouth which develop later on, which are similar to this, which are painless, which is there in my tongue or a buccal mucosa, I need to see a specialist. Now, when you complete a case like this, it is not just a case which you have completed it and then you get a chance to show it in various conferences, but long-term ramifications of these cases are that you educate the patient in that way. You make the patient aware. Once the patient is aware, Now the power is in patient's hands. Now he or she knows that any kind of ulceration or a white patch in the mouth, I need to see a doctor, especially if it is not painful. The patient is now aware of the further development of any such lesions. So we were quite confident that anything happens to him, he won't die of cancer. I think I've more or less put my words to this august audience. To conclude, I think I would just say this, that most of the mucosal lesions are asymptomatic. Patient will not know the sinister implications of this. A dental surgeon's mind should know about the red and the white lesions, and their eyes should be capable enough to see those white and red lesions. Good money, implant prosthesis, surgical procedures, good money. I agree. But then, if there are patches in the mouth, they might be reflecting a sinister systemic disease, which might lead to failure of these major or minor surgical procedures. So any mucosal lesions in the mouth must be managed prior to or simultaneously with the procedures, but never following them. I mean, you put an implant or you give a prosthesis and then you start managing the white or a red patch or an ulcer, is not will not really work out the way it should have worked out. So work on the mucosal lesions first, get a healthy mouth, and then do all the rehabilitation treatments which you're planning to do. This is one of my favorite lines when I'm dealing with red or white patches. Not all red or white patches in the mouth will convert to small cell carcinoma. There might be lichen planus, there might be inflammatory ulcers, but even one small cell carcinoma, if you're able to nip it in the bud, that must have started from that mucosal lesion. So you scout for every red or white patch in the mouth, and maybe we take the tumor burden down. And even one OPMD managed at early stage reduces the tumor burden significantly. This is a algorithm which we follow for the oral cancer screening. This is for the oral cancers, basically OPMD screening. Covers most of the red or the white patches of the lesions, which I had just talked about. And my regards to my guru, my teacher, Professor V. Ramesh from MGPJ Pondicherry, and that is my workplace where I enjoy peeping into the microscope into the world of blue and pink. And thank you so much.